All right, let's dive in. Today, we're stepping right into one of the most high-stakes situations you'll face in the emergency department, managing the poisoned patient. These cases are common, they're complex, and they demand a calm, systematic approach when everything around you feels like chaos. Let's get started. The doors fly open. A patient is wheeled in, barely conscious. The story's fuzzy and overdose. And right away, the clock starts ticking. Your mind is just racing with possibilities. In that moment, with all that pressure, where do you even begin? This isn't just some textbook question. This is the reality you're going to face.
So from the second that patient arrives, you're juggling two missions at the same time. Mission 1, obviously, is to preserve life. We're talking immediate medical resuscitation. But running right alongside that is Mission 2, assessing the intent. Was this accidental or was this deliberate self-harm? That second piece is absolutely critical and will guide everything we do long after the medical crisis is over.
Okay, so how do we bring order to that chaos? We fall back on a framework that always works, the ABCDEs of resuscitation. It's a simple, systematic way to make sure we tackle the most life-threatening problems first. In toxicology, believe me, this structured approach is your absolute best friend.
Let's quickly run through it. A and B, airway and breathing. You know, respiratory failure is one of the biggest killers in overdose. If the patient's GCS is 8 or less, you don't wait. You secure that airway. C is for circulation. That means getting IV access, getting them on a cardiac monitor, and treating any hypotension, usually starting with a bag of fluids. D is disability. Check their neurological status, and this is where we think about our universal antidotes. And finally, E, exposure. Get all their clothes off so you can look for hidden clues, patches, injuries, you name it.
So speaking of disability, let's talk about the Coma Cocktail. When a patient comes in with an unknown altered mental status, we don't have time to wait for lab results. We act. We give this cocktail to reverse the most common culprits: dextrose for low blood sugar, naloxone for a possible opioid overdose, and thiamine. Now here's the golden rule. You have to remember this. Always give thiamine before dextrose. Why? Because giving sugar first can actually trigger a devastating neurological injury called Wernicke's encephalopathy in at-risk patients. It's totally avoidable if you just remember that simple rule. The second you even suspect a poisoning, you need to reach for your best resource. In the UK, that's going to be Toxbase or the National Poisons Information Service. Use it immediately, right at triage. It gives you instant, substance-specific advice. Look, using this isn't a sign of weakness. It's what smart, safe doctors do. It can literally be the difference between life and death. Okay, so we've stabilized the patient using our ABCDs. Now our focus starts to shift a little bit. We start thinking, how can we stop more of this poison from getting absorbed? And how do we help the body get rid of what's already in there? This brings us to the next big topics: decontamination and enhanced elimination.
Now, how we do decontamination has changed a ton over the years. You know, the old school methods like stomach pumping or making someone vomit, we just don't do that anymore. They're risky, think aspiration, and they're pretty much useless after an hour. Today, we're much more targeted. Our main tool is activated charcoal. And in really specific cases, we can even use hemodialysis to literally filter the poison right out of the blood.
1 hour. If there's one number you take away from this section, it's this one. For activated charcoal to have a real shot at working, you've got to give it within 1 hour of the ingestion. After that, the poison has probably already left the stomach and the charcoal can't do its job. So remember, that 1 hour window is absolutely key.
But, activated charcoal isn't a magic bullet for everything. It won't bind to things like lithium or alcohols. So for those really severe poisonings, we have to bring out the big guns: hemodialysis. This is a true life-saving measure for certain toxins, the ones that are small enough to be filtered out of the blood. We're talking about things like aspirin, toxic alcohols like antifreeze, and lithium.
Okay, so the patient is stable. For now. This is where the real detective work kicks in. And the key idea, the concept that turns all this chaos into something manageable, is a thing called a toxidrome.
Just think of a toxidrome as a poison's unique fingerprint. Different types of drugs mess with the body in very specific, very predictable ways. So by looking at the pattern, the heart rate, the pupil size, the skin temperature, a doctor can take a massive list of potential suspects and narrow it down to just a few key players. And get this, these fingerprints can be total polar opposites. Take an opioid overdose. It shuts the whole system down. You get these tiny, pinpoint pupils, breathing slows to a crawl, and the patient's in a coma. But a stimulant overdose from something like cocaine, it does the exact opposite. It revs the body up into overdrive, huge, dilated pupils, a heart that's racing, and the person is super agitated. Just by looking at the patient's eyes, a doctor can immediately slice the list of possible causes right in half. So recognizing that pattern, that toxidrome, is step 1. Step 2, that's about deploying the right weapon. Let's take a look at a few common culprits from the ER's rogues gallery and the specific antidotes doctors use to fight back. First on our list is one of the most common and honestly one of the most deceptive, paracetamol, which you probably know as acetaminophen. The danger here is just how sneaky it is. A person can take a lethal dose and feel totally fine for hours, all while their liver is being silently and irreversibly destroyed. But here's the amazing part. If doctors can identify it and give the antidote, a drug called N-acetylcysteine, or NAC, within about 8 hours, it is nearly 100% effective at preventing that liver damage. It's an incredible save, and it just hammers home how critical that early detection really is.
Now, let's zoom in on that opioid toxidrome we mentioned. The classic signs are so well known they're called the opioid triad. You've got coma, those tiny pinpoint pupils, and respiratory depression, which is that dangerously slow breathing that's often the killer. The antidote here is naloxone, a drug so powerful it can literally snatch someone back from the brink of death in just a few seconds. And on the complete other side of the spectrum, you have the sympathomimetic toxidrome. In the ER, they have a pretty memorable, if blunt, shorthand for this one: hot and crazy. The patient is burning up, their blood pressure is through the roof, and they're often incredibly agitated, maybe even psychotic. For this, there isn't one single magic bullet antidote. The whole goal is just to calm the storm. Doctors use benzodiazepines to get the agitation and seizures under control, and they have to aggressively cool the patient to bring down a body temperature that can be life-threatening. The key here is that sometimes the best treatment is just managing the chaos, not trying to reverse the cause. All right, let's level up the difficulty. Some very common heart medications, like beta blockers, can be absolutely lethal in an overdose. These drugs go straight for the heart, causing a dangerously slow heart rate and dropping the blood pressure to critical levels. So for these cases, doctors can't just rely on one fix. Instead, they launch this multi-pronged attack. They'll use a whole cocktail of agents: glucagon, high-dose insulin, calcium, all of which work in slightly different ways to support that failing heart.
All right, we've stabilized them, we've thought about decontamination. Now it's time to play detective. We're hunting for clues by looking for toxidromes. A toxidrome is basically a constellation of signs and symptoms that points to a specific class of poison. Being able to spot these patterns is like a clinical superpower. It lets you make a diagnosis and give a life-saving antidote way before any lab results come back. This table really boils down some complex toxicology into patterns you can recognize, and spotting them is everything. For instance, if you see a patient in a coma with pinpoint pupils who isn't breathing well, that's the classic opioid triad. The antidote? Naloxone. Or if you see a wide QRS complex on the EKG in an overdose patient, you should immediately think of tricyclic antidepressants, and the treatment is sodium bicarbonate. Each pattern points you directly to a specific, life-saving treatment.
Welcome to the Explainer. All right, today we're jumping straight into the ER. We're going to break down exactly how to manage a paracetamol overdose. And trust me, this is something that happens way more often than you'd probably guess.
So to really get a sense of why this is so important, let's start with a question. What do you think is the single biggest cause of acute liver failure in the Western world? I mean, think about it. What could it be?
And the answer? It's probably not what you're thinking. It's not some exotic virus or anything like that. It's an overdose of a super common painkiller. Yep, paracetamol. The stuff that's in pretty much every single home. Okay, so picture this. You're a doctor in a busy ER. When do you start getting seriously concerned about paracetamol toxicity? Well, it really boils down to the dose. It's all about the numbers.
So here's the first number you need to know. If someone's taken less than 75 milligrams per kilogram of their body weight, you can breathe a little easier. Severe toxicity is pretty unlikely at that dose. It's kind of like a safety threshold. But this is the number that really matters. If they've taken more than 150 milligrams per kilogram, or for an adult that's just over 10 grams total, you have to suspect toxicity. As soon as you hit that number, the clock is ticking. It's a race to save their liver.
Okay, so the alarm bells are ringing. What's next? Now you go into investigation mode. You need to gather evidence and fast. And it's not just about what they took, but when they took it. That's a huge piece of the puzzle.
And there's a really clear protocol here, a 4-step process. First, you get the story, exactly when and how much they took. Second, you get a blood sample to check the paracetamol level. Third, you use that level to plot it on a special chart. And fourth, you run all the other labs to see what the liver's doing.
I said the clock is ticking, and I wasn't kidding. Timing is absolutely everything. After just 1 hour, some options are already gone. There's this little window between 1 and 4 hours where activated charcoal might help. And that 4-hour mark, that is the magic number for getting that first blood test, because that's when the drug level is at its peak.
So you've got this blood level from the 4-hour mark. Now what? You plot it on something called the Rumack-Matthew nomogram. Sounds complicated, but it's basically a risk assessment chart. It tells you, based on that blood level and the time, just how likely it is that the liver will be damaged. This thing is a game changer.
But, and this is super important, this amazing tool has its limits. It only works for a single, one-off overdose. If someone has been taking too much over a few days, or if they show up a day later, the nomogram is useless. You just can't use it. You have to rely on other clues.
All right, so you've confirmed the risk, either with that fancy nomogram or just based on the story. Now we get to the hero of the story, the antidote.
It's called N-acetylcysteine, or just NAC for short. So here's how it works in a nutshell. When you overdose, your liver gets flooded with this toxic byproduct, and it just can't keep up. NAC basically comes in and gives the liver the building blocks it needs to create more of its own natural bodyguard, this stuff called glutathione, to fight off the poison.
And get this, NAC is unbelievably effective. If you start it within 8 hours of the overdose, it is nearly 100% effective at preventing liver damage. 100%. That's why that 8-hour window is so critical.
So, when do you pull the trigger and give NAC? Well, there are a few clear signs. You give it if the nomogram says go. You give it if the dose was definitely over that 150 milligrams per kilogram danger line. You give it for those staggered overdoses we talked about. And you give it if someone shows up late and they're already showing signs of liver damage, like their skin turning yellow.
So how do you actually give it? It's not just one quick injection. It's a whole IV infusion protocol that takes 21 hours. It's done in 3 stages, and the dose is carefully stepped down over time to keep the liver protected the whole way through. But what happens if you miss that 8-hour window? Or if the overdose was just enormous? Well, that's when things get really serious. The game changes from prevention to damage control, managing some really dangerous complications.
The big one, the complication everyone fears, is acute liver failure. The liver just starts shutting down. When that happens, the patient has to go straight to the ICU for intensive support.
And in the absolute worst-case scenario, the only option left might be an emergency liver transplant. And there are very specific criteria for this, called the King's College criteria. They paint a really grim picture. We're talking about blood turning acidic, the inability to form clots, failing kidneys, major confusion. If a patient hits these markers, their liver is in catastrophic failure, and you've got to get a transplant team on the phone, like right now.
Okay, so let's shift gears. After all the treatment and monitoring, how do you know when it's all clear? When can you finally say the patient is safe and can go home?
Well, there are some pretty straightforward rules for discharge. Either the dose they took was never in the danger zone to begin with, or if they did need NAC and got it within that magic 8-hour window, they can usually go home after the full 21-hour treatment is done. The key is, of course, that they're feeling fine and have no symptoms. So there you have it, a really effective step-by-step protocol that literally saves lives every day. The medicine is clear, but it leaves you with a bigger question, right? For a drug that's so easy to buy, that's in almost every house, is the danger of it really clear enough to everyone? Just something to think about.
But what happens when the picture isn't so clear? What if the patient doesn't fit neatly into one of these toxidromes and they're just unconscious? This is honestly one of the biggest challenges in emergency medicine. An unresponsive patient is a total black box. You have to act, and you have to act fast, but you're working with almost zero information. So what's the play?
doctors turn to what's often called the Coma Cocktail. Now, it's not a single drink, obviously. It's a combination of things given through an IV that works like a safety net. First, dextrose, just in case the coma is from dangerously low blood sugar. Second, naloxone, to cover a possible opioid overdose. And third, thiamine, a vitamin that prevents a very specific and very preventable type of brain damage. And even with this broad cover-your-bases approach, precision is everything. There is one crucial, non-negotiable rule: thiamine must be given before the sugar. If you give the dextrose first in certain patients, you can actually trigger the exact brain injury you were trying to prevent. It's a perfect little example of how a tiny detail can mean everything.
So let's say you've done everything right. You've resuscitated the patient, you've given the right antidotes, and they're starting to stabilize. The immediate crisis is calming down. But guess what? Your job is not done. This last phase, disposition, is absolutely crucial. Where does this patient go next? Do they need an ICU bed, a monitored floor, or can they go home? Getting this decision wrong can have huge consequences.
So who needs that ICU bed? Here's your cheat sheet. Anyone who's hemodynamically unstable, has a low GCS, or is still seizing, that's a no-brainer. They need intensive monitoring. But also pay super close attention to anyone who's taken a sustained-release medication. These patients are like ticking time bombs. They can look fine for hours and then suddenly crash. And of course, any evidence of organ damage means they need to be admitted.
Let's circle all the way back to our dual mission. Once you've managed the medical emergency, you have to address the why. For any intentional overdose, a psychiatric referral isn't a suggestion. It is mandatory. It is a non-negotiable part of their care. Once they are medically stable, a mental health professional has to assess their risk. Discharging them without this step is a huge failure. We have to treat the whole person, not just the poison.
And this right here is the main takeaway. The patient who overdosed on paracetamol but looks totally fine. The one who took a sustained release pill that just hasn't kicked in yet. Toxicology is full of deception. The danger isn't always obvious right away, but that calm, systematic approach, from your ABCDs all the way to a thoughtful disposition, that is what turns a potential catastrophe into a life saved.
So, we've walked through the whole framework, from start to finish. You have the tools, you have the structure to bring order to that chaos. But the final question really is for you. When that patient rolls through the door, when the pressure is on, will you be ready? If you master this approach, if you make it second nature, you will be. You'll be ready for when every single second counts.